reconstruction course. We are already running late, and I would like to invite you all for this course on centration of the capsular bag and stabilization. So we have this interesting course coming up, and for this course I would like to invite Dr. Rohit Om Prakash to please come up and please deliver your talk. Thank you so much.
Thank you, Dr. Priya, for inviting me over. So she has asked me to talk on addressing zonulopathy with CTRs, segments, and devices. Well, the basic fundamental in management of subluxated cataracts or zonulopathy is that we need to conserve the intact zonules, we need to create an intact rhexis, we have to complete the different steps of phacoemulsification and implant IOL with bag fixation to the sclera. So these are the basic fundamentals around which the whole game is. Well, we have to realize that there are certain basic pearls which we have to know. As far as the planning is concerned, a detailed history is obligatory and mandatory. Both eyes need detailed examination. Slit lamp examination for phacodonosis or some subluxation has to be seen. Dilated pupil examination is obligatory and mandatory. Supine position is required for us mortals, but not for Dr. Chi, because it doesn't make a difference how much subluxated it is. But we people, I like to do a supine examination to see the extent by which the lens, when the patient lies down, how far it goes down. There are different ways which Dr. Chi would show how she pulls it up. Site of incision is very important. That should be not ideally in an area where the zonules are not there. Choice and timings of capsular hooks is also very important. We have moved on from implanting CTRs in the beginning with capsular hook. Now capsular hooks have come, which have helped us delay the insertion of CTRs. So CTR insertion, in other words, needs to have the insertion technique is very important, the timing is very important, cortical cleanup, how you have to do, and not to forget how we use the nucleus as a scaffold, which can help us delay the insertion of these external aids. Scleral fixation of IOL, different means. We have all a big array of methods by which we can. So let's see first the signs of zonular weakness. You can find that there is difficult because of lack of counter traction to start the rhexis. So this is another patient where you will find that there is striae formation. So this shows that there is a sign of weakness. Another patient where you would find that the weakness is there. You can use a pointed tip. You can use a cystitome for that matter. You can use in these patients where the insertion is difficult, you can use by what do you call Zepto for your advantage. You can use Femto also. So these are the different things how you can initiate the rhexis. So these are the different methods how you can. So it's a double pinch method which is being used to initiate the rhexis. So that is one way. This is the radio frequency by Herschel Tuck, courtesy him. He uses this to create a rhexis. Then Fugo blade can be used. I don't know how many of us have Fugo blade. Zeptorhexis can be done, and you can do a Femto too. So these are the different ways how you can initiate the rhexis. At times, the patients do have pseudo exfoliation, but contrary to your expectation, the zonules are intact. And the idea in these patients with zonulopathy is to create a large rhexis, as David Chang has taught us. So this is another way how we can do the rhexis. This patient has, you will find that there is some bit of subluxation in this part. So first of all, the most important point is that we are farthest away from the point of where the zonular weakness is there. And the initiation has to be in the direction, and I find that it is difficult. Stable chamber settings, then you can use a pointed chopper, a pointed cystitome to your advantage. then you can start doing this. And once you reach this point wherein you have created at least 1 to 2 hours clock of rexes and the flap of rexes, this is the time when you can insert a capsular hook. There's a big no, I delayed it. Ideally it should not have been delayed. And so capsular hooks in this patient is being used. Ideally capsular hooks should be used, and one should not use iris hooks, because capsular hooks, they help us. How do they help us? They act as artificial zonules. They provide anterior-posterior immobilization, and they, make there's no tenting up which you see when you use iris hooks. So now I'm just continuing. The moment I reach there, I'll use another capsular hooks to my advantage. You can use a bi-manual also, as Professor Chi shows, wherein one, capsular access forceps holds the capsule, and that immobilizes it, and you can use the other rex's hook, other rex's forceps, and you can continue with the rexes, and you can go on holding it again and again. So this is how the capsular rexes was completed in this patient. I used 3, or at times one can use even as many as 5 to your advantage. So this is how I use. And now the capsular rexes is moving without any problem, because the rexes, the capsular hooks have been able to provide me with the as artificial zonules. So now once this is done, there is adequate support, and one can continue with phacoemulsification. So this is another case which I would like you to see. Now here you would find that there is a around 100 degree of subluxation. So I've created the Hoffman's pouch right at the beginning, because that is the time when the globe is firm. Otherwise at times you have problem, and then I'm making the Hoffman's pocket. So once that pocket has been created, 1.7 mm, so incision site is right opposite the where the zonular dehiscence is there. Calibrated side port incision, because I want that the chamber should be absolutely stable. I'm using a cystitome, and I realize that I was able to initiate it. The direction of rex's the initiation has to be in the direction from the intact to the area where the zonules are not there. I'm trying to create a rexis. The rexis has to be created in such a way that it has to center the lens rather than center the pupil. I found that the rexis was too small for my liking, so I just spiraled it around and completed the rexis. So I've started using you see the fluidics which I'm using. The fluidics which I'm using are around 20. When I'm using 20, I'm trying to create in a situation wherein there is less flow of fluid into the interior chamber, because it has been shown by Vasavra et al. That if we use high fluidics, an intact anterior vitreous face can be broken, and you can have a vitreous prolapse. So having stable chamber settings and low fluidics is a very important factor when we are doing this, managing these patients with zonulopathy. Oh. So I had reached here. So now I'm continuing, I'm doing that, chopping it. Now, doing sort of, reverse chopping as Ronald Yorn initially, our own Dr. Chi had shown. So so now I'm rotating it. Now I'm going to show you a trick which I use. You should see that this area has zonular dehiscence, and this is a fairly hard nucleus. So now what I'm going to do is, I'm going to use this nuclear fragment as a nuclear scaffold. So when I'm using it as a nuclear scaffold, what I'm doing is that this nuclear scaffold, this hard nuclear fragment, is tenting up this area and helping me delay the insertion of a CTR. So this we published in JCRS way back in 2019. So you will find that I'm continuing to cover this area. So this is Another very small thing which you should bear, stable chamber settings. Now when the last nuclear fragment is there, I'm putting a CTR. So CTR direction is also very important. So CTR direction, you should, if the, the zonular dehiscence is less than 90 degrees, you can put it either where the zonules are intact, but when it is more than 90 degrees, then you should go from the area where the zonules are intact. Dr. Chi, any comments about that? Would you like to add?
I think just once you have hooks in place, to me, as long as you fully fill up the bag and distend the bag, it doesn't matter which way you go.
Yeah, but if that has not been done,
If that's not been done, then you go from intact to non-intact.
yeah. So that is a very important factor, because yesterday Dr. David Chang showed spiral CTR. I think when he'll come, he'll show, and I think it's a wonderful this.
Not that easy to use. I have it. I prefer the standard plain injector.
Okay.
Much more difficult.
And what do you do? The tricks which you use for each one of us here to decrease the zonular stress which is there with the normal CTR, which is not there with the, the spiral CTR.
So I think what I do is the first part, I don't inject all the way. So I will just withdraw my injector. If I start injecting here, which is my favorite place, and then I will actually, as I push the CTR out, I will move my injector this side. So I'm not advancing this tip. I'm just laying it out here. And once at least 3-4 hours has been laid out, I then advance it. So it's already following the curvature of the capsule.
And you don't use an injector, don't you?
I use an injector.
So you use the injector through that side port?
Yes. No, through the main incision.
Through the main incision, okay. So this part done, so nuclear scaffold has been used. So since this was more than 90 degrees, so what I would be doing, so stable chamber settings. Now what is the trick in using, with CTR around, it becomes difficult to take out the cortex. So just see the direction in which I am doing. I am doing tangential stripping. So that can be done, or as Dr. Mohan Rajan says, you can do reverse stripping also. In reverse stripping, what he does is, if you're finding it difficult, you can go from the posterior lamella and go do it. So I'll be putting a 3-piece intraocular lens. Once that is in place, so I'm going to railroad it in. So that is how I'm railroading it in. And then I'm going to pull it out, and the IOL is centered. Okay, so I don't need. So next is, when there is an extreme subluxation. So I would like to make it interactive, because, there are different ways how you can bell the cat. And with Dr. Chi around here, I would take the advantage of her presence and, see how it has to be done. The pupil was not dilated in this young child. So I used intracameral adrenaline to dilate the pupil. Now I'm doing the compartmentalization so that there are different compartments, because I really do not want by any means, the vitreous to come forward. So once that is done, the air bubbles out. I've initiated the rexes. So this rexes, Dr. Chi, you can stop me wherever you feel you want to.
Just to make comment that in all these very young patients, right, even in the Marfan syndrome that we saw, sometimes when we use the word that this is a subluxated lens, we tend to think that this lens has shifted, but actually that's not so.
Yeah.
All right, it's just that the zonular support is loose there, so the lens has become more globular. So the shape has changed, but it has not actually shifted. So sometimes we do the capsular rexes, we think that this lens is here, and we want to put the rexes here, but actually not so. If this is the shape of the lens in a young lens, all right, or even a person who's had zonulitis from trauma when they were young, and then became older before they presented to you, and the lens is this shape, I would make the rexes follow the shape of the lens. And when you put the CTR in, you'll find it's perfectly circular and centered.
You will make it go like this.
I'll follow the shape.
Yeah.
Okay?
Great. So I think it's a learning all the way for me also. So now what I do is, I've started it. You see I'm putting stress to the zonules. So what I'm doing now is I'm inserting the capsular hook. Here also I committed a mistake because I want it to be a learning one. I have, I have taken it too far without the support of the capsular hook. Either I should have used the bimanual as Dr. Chi does it, or I should have, used capsular hooks to my advantage. Since the child was young, I was able to get away with it. So that is the thing which, you should learn from what I have done. So once this part is done, now comes how do I take care of the, the cortex out here. I am trying to do, hydrodissection, which I am not able to. So now I am shifting to viscodissection. When I am doing viscodissection, I have been able to separate it fully. So this is something, which you should. My question is, should at this point of time one implant a CTR, or would you wait for it? Because when you're trying to do, had I not visco dissected it, in that condition I would have put in, a CTR, because between the capsular hooks there is an area by which when you are aspirating, that can be aspirated. Your comments on it?
Actually, you don't need to hydrodissect and you don't need to viscodissect because it's so soft. You can just aspirate it like a congenital cataract because there's no nucleus in it.
Yeah.
And you could consider in this case using a CTS with the iris hook as your retractor because it would more evenly spread out the forces and make it more centralized.
Good, 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 good. So I continue now. So when I am able to, you see how I have retracted it. So why I have retracted it? Sleep. Ideally, one could have used a bimanual, because what you want is, you want to have different planes of irrigation and aspiration. So in this case, I have retracted the sleeve. The irrigation is at this level, aspiration is at this level. These are very small things. And you can see that the IOP which I am using, IOP is 28. With this 28, what is happening is, I am not in any way going to create a situation wherein there is going to be, break of anterior vitreous phase. No doubt in this children with some support of zonules, it's difficult, but still low fluidics will really help. So I continue now, and so I'm able to, achieve the delivery, the aspiration of the cortex matter, because the child was too young for anything, and without any issue it has been done. Stable chamber settings, these are very small things which you have to realize, because you are trying to, as I showed in my first slide, you are trying to conserve the zonules as well. So now once that is done, CTR is being pulled in. I would have preferred that this CTR should have gone like this. So it is going in like this. Dr. Chi, is it okay if I continue like this?
Yeah, no issue.
No issue, yeah. But in your hands, but yes, for novice surgeons, you should ideally go do it the other way around. And how do you see that the capsular hooks don't come in the way in such a situation?
I think it's a different plane that you're inserting it, so it really doesn't get engaged.
It doesn't make a difference. Yes, absolutely correct. So I'm moving on, and at this point of time, with almost in, what I'm going to do is I'm going to use the Sinskey hook to just push it in. So once that is in, now I'm going to use the CTS. So there are different ways how you can fix the bag. So what is do you use CTS or do you use, yeah, please.
Just a CTS should be adequate.
Yeah, yeah. So there are many devices nowadays, which people use. So you just place it in. So ideally Gore-Tex should have been used. So which I think she would have asked me why did I use, because that is not so freely available in India. So these do have natural fragmentation of the of these sutures. So I'm going in. It's a partial sclerotomy which I have created. Railroading it in. So you have to be wary of the fact that when I'll just show you when I do it again. So I'm just taking it out. Now I want you to see what I'm doing, because I'll move it left, right. Why? Because I do not want any entrapment of the corneal tissue. Because at times, if you do a corneal entrapment, it creates a, yeah, Dr. Chi, you were about to lift the, yeah, okay. So I just do it and then I take it in, I railroad it in, go, then move it. This is unedited because I want you to see how, you know, if with both your hands, you know, you're able to, and see how closely I am holding. One should not have a long, you know, for better control, I would like to you to see how I did it, because this is also very, you see how close I am holding it. So when you hold it close, you have better control. Dr. Chi, would you like to add something? How do you hold it? It doesn't make a difference.
It doesn't make a difference,
But-
I think.
But
But be careful when you pull it across. If you have a long needle length, it can prank the PC at this stage.
yeah, and yeah,
Yeah.
that is also very important. So for better control, for two things, corneal entrapment, and if you have a longer one, you will not have a good control. And I have had a PCR with a long control. I couldn't control it, and I just hit the posterior capsule. So this
So
is
the other thing I was going to say is that, you know, if you have a problem trying to get your needle in, especially if you have a small pericentesis, then I just put my viscoelastic cannula and I just follow along.
okay.
Because the viscoelastic cannula will open up your incision. So you just follow your needle along your viscoelastic cannula and then you'll get into the AC without catching the corneal lamella.
Okay, great. So now I think I've already shown that. So this is going in. The second one. I'm pulling it. Now I will center it. The capsular axis is small, but somehow it is centered. Would you have preferred to have a larger one, or it's okay?
As long as your IOL can get in.
Yeah, now the lens will be implanted and that will be done. Safe times. Now I would request Dr. Chi to take over and take it to the next level.
Okay, so, you know, when I was given this topic, I actually decided I will speak on both the subluxated crystalline lens as well as the intraocular lens. So my financial disclosure is really not relevant to this talk. So I'm just going to show you the use of Gore-Tex, because many people look at this suture and say, how do I use this? All right, and when I show a lot of things moving around, people are very confused. So, yeah, so just to show you that this comes with a needle that's kind of short and fat, and actually it's not meant for ophthalmic use. All right, so this is really off-label use for the eye. Of course, you could avoid all this by paying for a nice instrument like a micrograsper like this, going through a sclerostomy, and you just pull the suture through, rather than use this device, which we call the suture snare. So this is a very simple concept. If you have a modified Sony CTR here, and you have a suture loaded onto it, how do you then get the suture loaded onto it to your scleral fixation point? So if I had something like this, which I would call a lasso, I can throw the lasso out there, and I can pull on the lasso, and the suture should then come in. So this is actually a very simple device, which I've used the suture. It's a very, very long suture here that we have. All right, it's 46 cm, all right? And you don't need 46 cm to tie your CTS and your CTRs. So the excess suture, actually, I just thread it through this needle, and I bend the needle, all right, fit it with an insulin syringe, so I trap the edge there, so it doesn't slip in. And then on the other end, this is left long, so this can act as a lasso, and I'll show you if I had the eye in place now. It's really simple, right? I'm going through the sclera here at the entry point, and then I pull it, and bingo, right? I've just lassoed the end of the suture to my scleral fixation point through the Hoffman's bucket. All right, so this is
something I conceptualized on the table without drawing. When I was faced with the problem, I created the suture. All right, so that's just what is done. It's just threaded through, and you'll see the video below that shows exactly that. But here are some tips, all right? Very important, keep the suture dry, which means that your hand should also be dry, because as you saw, I actually grasped the suture with my fingers. I'll just play this again. And I do not use forceps that will press on and crimp that suture, flatten it, and then you won't be able to get through a 27 gauge needle. It can go through a 30 gauge TSK needle as well, which I use for the pediatric mafans, all right? Otherwise, these little sclerostomies created by the needle can actually leak. So you then bend it to whatever angle you wish to, all right? Then after creating a Hoffman pocket, I use 2 mm posterior to the limbus, and I go in vertically, and when I come in around, once I've entered the sclera, I turn horizontally, and you can see I've actually pulled out that suture. And one trick is to pull back the needle once you're in. You see I've changed angle. I pull back, and then you see the loop get released. Okay, once that loop is released, you use your Coughlin hook, and then you just draw it out. So what you do with your Coughlin hook when you go in is, after putting dispersive viscoelastic to push down the capsular bag to create space, I use the Coughlin hook by turning it flat, and then I depress that capsular bag complex so that my needle does not hit the anterior capsule. This is very important to avoid ripping your capsule. Okay, so this is simple. Any questions on this before I move on? It's okay? Yep? Okay. So let's have a look at a case like this, right? You can see that there's no support there, and I've actually scanned the capsular bag with this femto. Okay, and I inject dispersive viscoelastic subcapsularly. You saw how clean that capsule was. And then now I begin to inject, okay? And you can see actually the CTR is very clean in the equator. You don't actually see it trapped in the cortex at all. Now, when you have very severe subluxation, you really need to put it in early, because your nucleus is the scaffold. You don't have to worry about distending the bag, etc., etc. All those things don't count. As long as you have the bag reasonably supported, the femto actually helps you with this in breaking up the nucleus, and you don't necessarily need to rotate this nucleus. You can just tumble it out, and then with moderate parameters, you've done the nucleus removal, stabilize the anterior chamber before you take instruments out. And you'll see the cortex is not trapped. Okay, you don't see me struggling at all if you've inserted it in the plane that you have actually created a viscoelastic. Here is creating the suture snare. All right, you bend it. All right, now loading on the CTS. So I cut off a segment first. I leave the needle on so that I can load this onto the CTS. Insert the CTS. Create the Hoffman pocket. All right, at least half scleral thickness, because the knot must not erode through. All right, extend that loop with the Coughlin hook. Hook it out through the incision. And then thread one end through. Pull the 2 ends. Leave it a little slack. Okay, you'll see why in a while. You pull back on the needle. All right, so now you have that lasso come out of the main incision. Okay, you leave it a little slack because you're going to hook it out of the Hoffman pocket. You don't want to suddenly pull on that suture. You can see it move, right? So you always leave it a little slack in the anterior chamber, and you look at the IOL for centration. So I do not fix the bag until my lens is in. It tells me exactly where that bag is, and I always tighten a bit more when you're doing 1 point fixation, because that knot will settle 2 mm posteriorly from the limbus. Okay? Then you have an IOL that's centered. Now this is a more difficult case. This is where you need to first start by clearing vitreous. Okay, so there's vitreous in the anterior chamber, and you know the vitreous is supporting the lens. And if you don't have a couch, actually you can just lie the patient between 2 chairs in your clinic. I remove all the vitreous that supports the lens, and I'm indenting, all right, with a cotton bud there, spear with a 27 gauge needle on the anterior capsule, and then lift it up. You can see I've got all my hooks ready. Now this is a bimanual technique, all right? So from this stage, use non-tooth forceps, not the capsulorhexis forceps, the non-tooth forceps if you're holding on to the capsule. So I do a bimanual technique, all right? And then you can apply whatever hooks you want. at this stage just to provide the support. Iris hooks are easy to manipulate, and you can see really there are no zonules. You do a bimanual technique and look at the equator so that you can center your capsular axis. Okay, so all these are all ready. I've done my paracentesis and everything's at hand. So once you've got it to anatomical position, you don't have any visuals, you don't have to worry about that. Again, inject dispersive viscoelastic just under the capsule, insert the CTR in this plane. So I do this 360 degrees around. And then if you wish some hydrodissection, it's not crucial, because once you've done your visco dissection in the subcapsular plane, 360 degree around, your nucleus can tumble out. Okay, this is doing a cross chop, so you don't have to rotate that much, and you can just tumble your nucleus out. In fact, my parameters can go back to normal because I've sealed the space between the iris and the posterior segment, so no fluid can be misdirected posteriorly, and we don't get vitreous coming forwards because the gap between the two is sealed. Okay, if you don't seal the gap, you don't have the hooks, or you don't have your capsular bag centered, you will get fluid going behind. You can get fragments going behind, and you can get fluid pushing forward as well, and that's how you inadvertently catch the capsule. Okay, so after creating Hoffman pockets, in this case, definitely with only like 2 clock hours of zonules intact, I will need to actually do 2-point fixation. So the CTS goes through a 2.2 mm incision very easily. The 1.8, when I put it in, I just kind of curl the fixation eyelet a little bit more, and it will slide through a 1.8 mm incision, right? Especially if you're doing pediatric cases. And then this is what you've seen in already the previous video. Insert the CTS. I leave a hook there so that I can actually easily slide the CTS into the bag. You can see me entering the angle because I do not want to hit the anterior capsule when I come in. Okay, so I first enter and then I change the direction. So that's the lasso, which I explained earlier. Leave a little bit of slack. Okay, you can now position your instrument, your devices. All right, this is retrieving the sutures from the Hoffman pocket. And once you've got that done, you're going to look at the RL for centration. So you throw 2 knots, adjust your tension until you're happy, and you don't have to tie tightly for this, okay? Because you have 2 points of fixation. As long as they're symmetrical, your lens will be perfectly centered, okay? Okay, so now let's go to RL fixation. So I'm still going to use Gore-Tex suture, and you can do it in various ways, whether you do it directly or whether you are having a CTR there when you just loop around the CTR together with the haptic, or you're going to insert a CTS to add to the support. So in this case here, this is a single piece monofocal non-toric lens. Okay, so first, when my hands are dry, I create the suture snare. Okay, and then I touch the eye now. As Rohit mentioned, when the eye is firm, it's nice to do your Hoffman pockets. Okay, so normally I would go to 2 mm posterior, the limbus. I used to do 1.7, now I prefer to do 2 mm. And all you need is 2 paracenteses. Dispersive viscoelastic, suture snare, behind the complex. So your other paracentesis, you use a Coughlin hook. That's very, very useful because it also extends the lasso. You repeat now, going above the complex. Okay, so that's very easy. Thread the end through. You know, these sutures are so easy to handle. They're so easily visible as well. Okay, now when you tug on it, you can see the other side. Some dispersive viscoelastic, there's no vitreous there. There's a patient with retinitis pigmentosa. We're going through the capsular bag complex, extend that lasso. Okay, thread it through a fresh segment. And then we do the repeat, and we go above the complex. So this really minimally invasive, is really very quick. So this for a case where there's really no vitreous presentation. And once you've got it looped around, you then retrieve the sutures. And when you've done that, again, no tension, all right? As long as there is, you know your sutures are adequately against the haptic, All right, then you just tie 2 on 1. You can see me doing that routinely. It's the same on either side, and then you tie down 2 more throws, and you put that back into the Hoffman pocket. All right, so that's simple. Let's have a look at this other case. Where's the lens? Okay, this is a toric lens. Okay, so I'm again going to mark along the axis the Hoffman pocket, diametrically opposite sides, 2 mm, everything's ready. Prepare the suture snare. All right, you can use a 26 gauge needle, 30 gauge TSK, or 27 gauge. And then you see the lens float into view. Okay, so I'm holding on to this. This patient earlier had a CTR, but obviously that's not enough. Clear all the vitreous, as mentioned, that's the first step you really want to do. So you then get the lens into position. As I mentioned, this is the toric lens, and that's the axis. You can see the marks there. Come through posterior to the complex, go through the capsular bag at that junction there where the marks for toric axis are. Now you don't tighten too tightly and try not to widen where you puncture through the capsular bag. So this goes above the complex, and you want to balance the torque created by your sutures on the opposite side because they are placed side by side. You could do one in front and one behind the 2 mm mark as well. Okay, so I'm using forceps here, and it's the same. If you got a Coughlin hook, that would do the job as well. Okay, so you can see I've got a AC maintainer still there to maintain the pressure on the eye. All right, so now we're just going to retrieve, and it's the same. Every case is the same, but this is really minimally invasive. Okay, so once you've got that there, I will try just to fast forward this, and you'll see that actually this patient has got a really very, well-centered IOL. Okay, no vitreous in the AC. Now this was an orthopedic surgeon, and his surgeon who referred said, you know, can you preserve his lens? Okay, he's got a toric lens with quite a high toricity, please preserve it. So I marked it, and I'm matching it to the axis. So when I grabbed it, I just matched it there, and I had all my hooks ready to support it so it's in perfect alignment. Well, you know, I learned years later that this guy actually had the dead bag syndrome. He had a bit of summing ring, but I was able to even remove that from the capsular bag, open it up completely. All right, again, this is the suture snare, load a CTS, and I went in there exactly, and just next to where the support was needed, where it was really opposite the intact zonules, I actually have just created a fixation here through Hoffman pocket. Okay, I think you've seen this, so let me just go on. Right, so Gore-Tex really is the ideal suture for suturing the modified capsular tension devices. It's strong, it's flexible, it's easy to handle, and non-biodegradable. Gore-Tex scleral fixation of IOLs without capsular bag support is an effective rescue technique for reusing the in situ IOL, achieving excellent IOL stability. And the knot, very importantly, must be buried or adequately covered by the sclera. So make your Hoffman pocket at least half scleral thickness deep. And I use a diamond blade guarded at 300 microns. Thank you very much. Are there any questions?
Thank you, Dr. Chi, for this wonderful presentation, and it's always beautiful to see you doing using Gore-Tex so beautifully. Just for the benefit of the audience, would you like to give just a small tip, you know, maybe like, have you ever seen any degradation occurring in a Gore-Tex, and how important it is to put it into the Hoffman pocket, like, you know, to prevent the exposure?
I had a problem where I had used just a scleral groove, okay, because that patient actually had trauma going through the sclera there. And because of that, I couldn't really do a Hoffman pocket IC, so I thought I'll just get away with a groove. But that case, subsequently, the knot eroded. And what I did was that I tied a 9-0 polypropylene around the knot, and after putting a lot of povidone iodine on the surface of the eye, I rotated the knot into the eye and out again, so the suture was, the new suture actually followed the track of the Gore-Tex suture, so I didn't have to actually go in and thread everything all over again, okay? It's what I call a suture transplant, so that's how I retrieved the other end of the suture, I cut the Gore-Tex and then I tied the two ends of the Prolene suture, and then I didn't have problems thereafter. But it's not common.
Thank you so much. Thank you for this wonderful talk. And now we move on to none other than Dr. Chang, and he will be highlighting his talk on sulcus fixation. Over to you, Dr. Chang.
All right. Well, thank you. That's a tough act to follow. Sun-Pek surgery is so masterful. So I'm going to talk about a different situation where you don't necessarily know you're going to be in trouble because you just think you're doing a cataract surgery with pseudoexfoliation. I have no financial interest in this talk. These are some of my textbooks that kind of cover a lot of this, and some of the videos are there. So as we all know, this is the problem with zonulopathy, pseudoexfoliation, is it's not enough just to get the lens in the bag, preserve the capsule. That's hard enough. We then have to worry about late bag IOL dislocation with this contracted capsule 7 years later. Now look at this case where I inadvertently aspirated the anterior capsule, and I created a zonular dialysis. I think it's about 4 o'clock hours, so I'm going to put a CTR in. And I'm bending the CTR and trying to, and then all of a sudden I see the equator of the bag, and now I'm seeing like 5, 6, 7 clock hours of the bag. And so now, not only have I trapped the cortex in the bag, but look what's happening when I strip the cortex. I'm stripping the zonules, what's left, everywhere else, because that CTR is transmitting the force of what I'm doing with my instrument to all 12 clock hours of the zonules, which are deficient. So the CTR works against you when the majority of the zonules are deficient. It helps when the majority of the zonules are okay, and you can leverage them for the 3 or 4 clock hours that don't work. So that's the problem with the CTR by itself. So this is going to be, this is an older case, and I think it's about 2005, but it's what I call my index case, and I'll sort of go through why I did it. So you're going to see a little halo here, because when I indent, I'm having trouble incising the capsule. That little light reflex, like a halo, could be because the needle's dull, but in this case it's because the anterior capsule isn't taut. So it's wrinkled a little bit. These were the capsule retractors at the time. This was the 2nd generation from Dick McCool. And so I'm thinking, well, I know how to do phaco chop this way. I'm not pushing the nucleus against the capsule. I'm using the phaco tip to support the nucleus. And those 4 capsule retractors act like artificial zonules. So they keep the peripheral capsular bag from coming toward the phaco tip. Here, the capsule isn't taut, so it doesn't want to separate from the cortex. I'm missing the zonular counterfixation that holds the capsule still as I try to gently strip the cortex away. What I would do nowadays is put in the dispersive viscoelastic to put the posterior capsule in stretch, but here I'm just doing it very carefully, and then I'm going to put in my CTR. Now, I leave the capsule retractors in place because I know that there's a tendency for the ring to push the bag around, and I'm also using the secondary fixation, using my Lester hook to bend it. And with the monofocal, you see there's a bleb to the right. I like using a 3-piece because why not? You get a little more compressive force than a 1-piece. And being compulsive as I am, I'm actually enlarging the rexus here, because there is a tendency for that capsulotomy to contract, and if you keep it large, it will not do so. I don't think you need to go this large, but certainly don't leave it small. So I've kind of done all the things I know how to do, and I'm feeling really good because they got a bleb, we had this weak zonular case, and it looks beautiful now, right? So now this is usually when people applaud in the audience because I did such a good job. But there's still one thing I can do to screw this up. And what do you think that is? Yeah, well, I decided I'm curious, I'm going to shake the eye. And all of a sudden, oh my God, why did I do that? This thing is completely loose. The bag is loose. And so here I've done perfect surgery. I got it in the bag, got the CTR in, and it's loose. So kind of in the audience, you know, I'm going to give you a couple choices here. Leave it alone. You know, you saw a beautiful illustration of how you do scleral fixation. We could do the CTR. We could suture the haptic to the iris. We could move to the sulcus, put in an AC or iris claw lens. So how many people would do number one? Just raise your hand. Nobody would leave it alone, because that was, all right, one person, all right. How many would suture the CTR to the sclera? You just saw some great demonstrations that only one. Okay, so you're running out of choices, two people, okay. How many would suture the haptic? We actually have a haptic here to suture the iris. Then we don't, you know, okay, we have two people. How many would move it to the sulcus? 5 people. That means everyone else would take everything out and put an AC lens in, right? Because everyone else didn't vote. All right. So I am at a loss, and I'm thinking, God, it'd be nice to leave this alone. But if I saw this patient 5 years later and they said their vision had changed, and I see this kind of a pseudophacodenesis, I just know it's a matter of time before it's going to shake completely loose. So I'm going to move it to the sulcus. Now, it's a little hard because I put in a lens that has posterior angulation. And so trying to move the haptic from the bag upward into that space between the anterior capsule and the iris is going to be really hard. So the only real way I can control this to go in the sulcus is to move this lens into the anterior chamber. So that's what I'm doing now, and I'm sort of using my other hook as a ramp to bring both of these up. And then once both haptics are there, then I'm kind of used to this one haptic at a time, going just under the iris. Now I did enlarge my rhexis, which now I'm regretting, but I just carefully have to make sure because I want both haptics in the sulcus. And now I'm going to dial this one in, and this displacement of the IOL tells me I'm in the sulcus, because with a bag I wouldn't be able to do that. And so I've moved it. It kind of looks the same, but I have moved the location, all right? So what next? Someone suture it? All right, someone's doing this. So how many people want to test it and jiggle it? How many would jiggle the eye? Okay. How many people that this is like, we've done enough, we don't want to know anymore, would not jiggle the eye? Raise your hand. How many people would not jiggle the eye? Okay, yeah, you know, this is how we do it. How many people you wouldn't jiggle the eye, but you want to see what happens if I jiggle the eye? That's what usually happens. So okay, so here, jiggle the eye once. So I'm going to jiggle the eye and look what happens. So, wow, this is great. Now, why do I call this my index case? Because this is only one case that I don't have a lot of follow-up. I'm here on the operating table, but this is very unusual. I have put the same lens in the same eye, and I've shown you what it looks like in 2 different locations, one in the bag and one in the sulcus. And there's a dramatic difference. And this, to me, proves something must be going on. I must have 2-point fixation between the haptic and the ciliary body. And I kind of call this belt and suspenders. Normally we use the belt, which is the zonular ligaments circumferential to hold it. But in addition, I have these 2 points fixating like suspenders on my shoulders. And that's what does it. Now, okay, that's an old case. That's index case 1. This is index case 2. Here's another case where I've done this. Look, I'm jiggling the eye. It's a bad habit I have, but I'm jiggling it. And there's gross pseudophacodenesis. So there's a CTR in place. And it says, I've been here before. I wonder if I move this into the sulcus. Same thing, I have to use the Sinskey hook as a ramp, bring that haptic up into the anterior chamber. Okay, all right. So, you know, one of the things I could have done is I could have put in a capsule tension segment. Sun Peck showed a really nice, you know, how nicely that works with her Gore-Tex Hoffman pocket. But I've moved it into the sulcus now. The rhexis is smaller. I've captured it. And this is just to show, again, same lens, same eye in 2 different locations. And the pseudophacodenesis went away when I put it in the sulcus. So with that first index case, and with that, I now do this all the time. Now here's a case where I've got a nasal zonular dialysis due to trauma. So I've pulled this out. I've put my CTR in. And so what I'll do now is I've got zonular dialysis nasally, so I should orient the haptics 90 degrees away from that, right? But if I have to capture the optic, because if I don't, it's going to rotate in the sulcus. That haptic will go through the zonular dialysis. And what's different here, let me just go right back to here. You know, we're used to doing this when we have an open posterior capsule. We put the lens in the sulcus, capture the optic. But it's different when you have a bag because the viscoelastic will get caught there. So I have to vacuum out a little bit of it before I then plop the optic through there for the optic capture. Otherwise, what happens is that trapped OVD will sort of push the optic forward, and you'll get a myopic surprise. And the way you get out of that is I'd have to yag the posterior capsule, and that would then let the OVD bleed out posteriorly. Okay. Now, here's another case where there was diffuse zonulopathy. The capsule retractors helped me, and I think this rhexis is a little bit too small. So in order to do this technique, I'm just going to make a secondary little oblique cut and then secondarily enlarge it. These are MST capsule forceps, and they're very controlled, and I love being able to go through a paracentesis site so I don't burp out the viscoelastic, causing the chamber to shallow. And I think you can see here I'm trying to put viscoelastic to open up that space in between the iris and the anterior capsule, and this again lets me get into that space. So it is important that the rhexis isn't too small. Once in a while, the zonules are so bad I can't capture it. The bag wants to go back too far, and I would leave it in the sulcus. And I like using this AR40. It's a J&J lens because of all the three-piece acrylic monofocal lenses. It's the one that has a rounded anterior edge so that if it, for some reason, had to be left in the sulcus, I'm not going to get iris chafe. So this is that same step. You have to do this, is to go in and just aspirate. You don't have to get all of it, but what you can of the OVD that's behind there, because once we buttonhole the optic, it's going to be trapped there and it cannot come out. But you see that lens is in the sulcus, it's decentered. I think here I'm trying to rotate it. If I can get the haptics to 3 and 9 o'clock, I think that's probably going to help, because a lot of times, you know, when we shake our head and move our eye, that's the orientation of the saccadic movements. And then there's the optic capture, and then I'll retract that there, okay? All right. So what's nice about this is if you don't have the hardware there, because you're doing a pseudoexfoliation case, you're not sure, you didn't anticipate this, and I got through this, this is a way that, wow, I can just put this in the sulcus. All right. So why capture? Well, you now have a way to, there's a CTR in. I do think you want to have the CTR in. It sort of reduces peripheral stress on the zonules, but this will prevent capsular rhexis contracture. If the rhexis is centered, then your lens will be centered. It does prevent rotation. I showed you a case of a zonular dialysis, but even diffuse zonulopathy, you don't know if there's an occult dialysis, and if it's just in the sulcus, it might rotate, find its way through there, and you get a late decentration. A nice little benefit. You don't have to change the IOL power, as you know, when you do optic capture. Well, here is a capsule tension segment. This is an older video. In this particular case, I'm using at the time a 9.0 Proline, just another way to do it. This is before Rich Hoffman described the Hoffman pocket. And I'm going to make a little scratch groove and try to line this up with the zonular dialysis. So instead of a trocar, I'm just putting in a paracentesis on the opposite end so I can externalize the needles. And then here's the guide needle, and one is going to go over and one is going to go under. But I bring the needles to the other side so I can just shoot it across, but with that half thickness scleral groove, 2 millimeters posterior to the limbus, I'll be tying the knot and it just falls in there. So I do have to take down the conj. And so that will go in there. But then I'm going to put the IOL in. And again, this may be enough, but belt and suspenders. Maybe the belt is enough, but if I really want to be sure and it's a monofocal lens, I'm going to put this in the sulcus. So again, don't want to cinch it up too tight. This is, we don't have this lens anymore. Again, it's an older video. Star used to make this 13.5 millimeter overall length silicone 3-piece lens. And so I'm putting this one into the sulcus and then capturing the optic, even though I have my CT segment. What would you do with this case? It's a brunescent lens, pseudoexfoliation. I'm starting my rexus. Whoa, the lens is spinning already, but I kind of keep it small and just gently try to continue that rexus. You can see it's a black, whoa, wow, that's moving a lot. All right, so I guess I do have a decision point here. All right, so how many people would just start phaco at this point? How many people would do a CTR and then start phaco at this point? How many people would put the capsule retractors in first and then start phaco at this point? All right. How many people would just stop and refer at this point? Any other choices? Hooks and CTR. Do everything. How about CT segment and CTR, right? Any other choices? Extra cap, yeah. So now with something like this, so I'm not the best at SICS, and this thing is huge. So at this point, and this is like a hand motion eye, I'm just going to abandon my temporal, that's converting to a can opener. I've gone superior, going to abandon my temporal clear cornea. You could do SICS, but this thing is so large, I just want to get it out. So I'm just going to do a conventional anterior limbal incision. I'm not going to worry about taking extra time to suture, and we're definitely not going to worry about cylinder in this hand motion eye. So this is, I think, an underutilized technique, especially in the West and in the US, where residents don't get trained how to do this anymore. And we don't have as many rock-hard cataracts, but there's a couple benefits, okay? Because if I was to do phaco, it's going to be really hard on the corneal endothelium. Certainly, depending on your experience, a lot greater chance of PCR, retained lens, vitrectomy, retained lens material. Okay, look at that lens. You know, you don't see the lens when you phaco it because you dissect it apart. But notice there's some viscoelastic on the top, but the top is like flat, like on a table. And the bottom is concave, like a rice bowl or a soup bowl. So this is kind of interesting. Thank goodness the front is flat. That's how we can complete a rexus. It would be hard if it was upside down. And it tells you why it's so hard to chop through that and why it's so hard to crack, when you do divide and conquer, all right? So at this point, I've done my INA. I'm going to put in a 3-piece non-foldable monofocal. But here's the point I want to make. So not only did I get the lens out, but I don't have to worry about this lens decentering because there really isn't a bag anymore. And I don't really know whether the haptics will both be in the sulcus or one P-pod's out, but I can guarantee you one of those haptics, if not both, are going to end up touching the ciliary body. So I have basically created sulcus fixation, and I don't have to worry about a CT segment or any of the other hardware. And that's the benefit you get with an extra cap, okay? Because all the years we did nothing but extra caps, we never had this thing of late bag IOL dislocation. That all happened after the capsular rexus, okay? So if we have one more second, I've showed this a couple times, but look at this. This is actually a dead bag syndrome. Look at this huge zonular dialysis over here. And so this is the problem with the CTR. This is Dr. Shimawaki's innovation. He's from Japan. And this is sold through Corsa. Corsa is on the exhibit floor. And it has this fixed hook in the front onto which you drape the lead eyelet. And so when I open this up, the lead eyelet doesn't go in the fornix. It stays right in the center and it opens like a spiral. And it's really, really slick. To disengage, I'll turn everything slightly to the right, and that lead eyelet will fall off first, and then the trailing eyelet usually falls off second. This is obviously reusable. So it only just got, and it's really nice when you have capsular retractors already there, because as you know, this kind of runs into the retractors. You run into these other areas sometimes where the bag has a fold. You avoid all those troublesome areas by the lead eyelet not having to go there. So it's not, you can purchase it and put your name on and order it, but it's not actually yet available in India. And in the United States, it only kind of became available in December, January for orders. But I use this on every case now with a CTR. It's so slick, and it's such a neat idea. So thank you very much, and thank you, Priya, for inviting me.
Thank you, Dr. Chang. It was an excellent presentation. Okay, so I think with whatever time is left now, I would just like to highlight and showcase one or two videos. So whenever we have a decentered bag IOL complex, the most common problem that comes up is the vitreous bulge. So we have had lots of talks on, putting up the devices and how to go ahead, fixing up with the Gore-Tex and, having a 3-piece IOL and everything. So I would just highlight one or two videos right now that how we need to take care of the vitreous bulge around the subluxations. Now this is a video. This shows how, this is a case, where there is a segment where there is an absence of zonules. And now when you actually start doing capsulorhexis in these cases, and when you start doing a phacoemulsification, what actually happens is that, the fluid of the phacoemulsification, it actually goes around the lens from the communication which is there between the anterior and the posterior segment. So what happens is that, you are hydrating the vitreous at every point of time while you're doing a phacoemulsification. So what actually might happen during this is that, with the vitreous hydration coming up, you might have a bulge coming up from that area, and it manifests as shallowing of the anterior chamber when you take up these cases, when you have subluxations or you have colobomas, etc. So in these situations, it's a small practical tip that I usually adopt, and which we have described as a vitrectomy-assisted phacoemulsification. You just put a trocar in the area of dehiscence, and from there, what you can actually do is a dry vitrectomy. So what actually happens is that, you are debulking the vitreous from there. You need not put a fluid infusion because already there is so much of fluid behind. And it's a very limited amount of dry vitrectomy that you actually do, and then it leads to deepening of the anterior chamber, and then you can go ahead and do your phacoemulsification procedure. So this is one method by which, you can actually control the bulge of the vitreous that comes around. The only clinical tip here is that, when you put the vitrectomy probe, you should be seeing the tip of the vitrectomy probe. You should actually not cut the posterior capsule accidentally with the tip of the vitrectomy probe. So that is a very important thing, where to actually put the trocar and the vitrectomy probe. You have to put it in the area of the dehiscence so that you actually keep on seeing it. Now this procedure, it can be repeated as many times. It depends upon the length of the surgery, the density of the cataract, and maybe you might just need it once, or you might need it even twice or thrice. So you can do it as many times as you feel it is necessary during the surgery. And then, you can just stabilize this capsular bag with the CTR being placed. One of the clinical tip is here is that, now there are different types of CTRs also available. Many times what happens is that, CTRs, they might tend to hold onto the cortical matter which is present in the periphery, and then it becomes actually difficult to remove that cortical matter, as Dr. Chang showed in one of the videos. So these are the cases where, I actually like to take a 3-piece intraocular lens and go ahead. The reason being that, if there is any change, or if there is any vitreous popping up, or if there is any new condition that develops while doing the surgery, the same intraocular lens can be used, and you can be intraocular fixation can be done with this IOL. So here, this is just that you are just closing up the pupillary defect, and we're trying to finish up this case with this. So this was the vitrectomy assisted phacoemulsification, which actually becomes very helpful in some of the cases. This is the second case, again you have a light subluxation out there. Now there are cases where, some of the surgeons, we like to use capsular hooks, some of the surgeons, and even the timing of placing the capsular hook is also very important. Usually we try to do it after the capsular rhexis that is placed. But in this case, what actually happened was that as soon as the capsular rhexis and hydrodissection was done, the entire nucleus came up into the anterior chamber. So like it was something like you are doing a phacoemulsification in the anterior chamber. So once this nucleus is totally emulsified, you can just see that yes, there is a small, dehiscence, an area of dehiscence in one of the quadrants, and you have to be very careful when you're doing irrigation aspiration in that area. Lucky enough that you are still seeing that there is a dehiscence which is there in that area, and you could get away by not using capsular hook, but it is very much essential to place up the capsular tension ring, and so that it totally holds it back. Now this was a traumatic case. It was not a case of a progressive zonulopathy. So you can just place a CTR, and you can see how stable the intraocular lens is after doing this surgical procedure. Now in this case, what you actually see is that even after placing this, and when you're doing an IA, you again see that, oh, there is a decentration. So now this, you cannot leave it as such on the table. You need to take up this case, and you need to kill the bulge which is coming from behind. So once you do that, with the pars plana vitrectomy, be very careful of when you do this, because you might damage the posterior capsule. You have to be very careful, very diligently you do it. You shave off the vitreous, and then you see how beautiful it actually remains into its position. Scleral flaps were made for this case initially because, we were not sure if the lens would decenter and we would not be able, maybe we might have to do a glue dal, but nothing had to be done for this case, and the flaps were just sealed because they were made initially anticipating that, there might be some problem coming up during the surgery. But it actually did not happen. I think we're running short of time, so I'll just show this small clip which I want everybody to emphasize. We always, we have these capsular segment placed inside the eye. So capsular segment protrusion can occur. Why would a capsular segment protrusion occur? For example, you see this clinical case which is there. This case had an endocapsular segment. There was a 3-piece IOL. There was an endocapsular ring also inside this eye, and still the intraocular lens here was, it was shaking after a history of maybe 5 to 7 years of surgery. Leave aside everything. This was a complication which occurred, and it's altogether a different issue. But what I'm trying to highlight here is the fact that this is an endocapsular segment which was placed inside the bag, and there is a degradation of the suture here. Now this degradation of the suture does not hold the capsular bag into its position, and maybe because of this, there was a shaking of the capsular bag IOL complex, and that is why this patient, which was initially operated, had the lady, she had a pseudo exfoliation, and then this segment was placed, and just because the segment did not hold it into place because of the suture degradation, the bag was not stable. So this important aspect has to be taken into consideration, and anyway, for this case we had to remove the endocapsular segment totally. So another important thing that we need to take care of is that, when you place the capsular tension segment, it should be placed into a proper plane, properly sutured, and initially I think maybe some of the surgeons, they also used a tenosuture, but we do not recommend using a tenosuture because now we have newer techniques, And we also saw Dr. Chi. She showed us, how beautifully Gore-Tex can be used and how it can be sutured into its place. Surgeons now, they're also using the Prolene suture, the 6-Prolene suture, making flanges and fixating up. So these are some of the important things to be taken into consideration whenever we have a subluxation. I think I need to wind up because we're running short of time. Thank you so much, everybody, for being here. Thank you. If anybody has any questions, we can just take up those questions, but we need to wind up the session. Thank you so much.